Here we are at the second date of our webinar sessions. You are all welcome. My name is Francesca Farese and I'm a sales representative for Gloreha, which is a company based in Brescia, a northern town in Italy. For those who don't know us yet, our company develops robotic devices for hand and arm rehabilitation in neurological and orthopedic fields. Therefore, today the title of our discussion will be the role of robot-assisted therapy in patients after acquired brain injury. You will virtually meet PhD Kristina Oidekrova, who works as a head and researcher in Rehabilitation Center Kladruby in Czech Republic. She's a very smart woman and therapist. For this webinar, we received many registrations from Europe to Asia and many other countries. So good morning or good evening, considering the part of the world from you're watching us. I inform you we will stay together around 2 hours. During this time together, we kindly ask you to pay attention because the webinar will be quite interactive. So we will launch some surveys and you will have to reply to some answer at your disposal. For those who have questions, you can write them using the chat. We will select them. And at the middle and at the end of the presentation, our PhD, Kristina Oidekrova, will be glad to answer to the most interesting ones. It is time to begin. But first of all, we would like to spend some words more thanking the company Electromedical Center for its collaboration and Professor Michele Vecchio from University of Medicine and Rehabilitation in Catania. So now I will ask to Professor Michele Vecchio to join us, if he can hear us. Just a few seconds. Okay, now it's connecting. Good morning, Professor Michele Vecchio. I will pass the word.
Good morning everyone. First of all, I would like to thank Electromedical Center and Gloreha for this opportunity and Kristina Oidekrova for participating to the meeting. Thank you. Hello, Kristina. Welcome on the stage of our graduate school. Kristina is a robotic rehabilitation expert. She works at the famous rehabilitation center in Kladruby in Czech Republic. Kristina, it's a real pleasure to have you here as a speaker, and our resident doctor will be happy to hear your report. And I wouldn't be surprised if after your lesson, any of our doctor will want to ask for a training period at your hospital. So this may be an additional task for you, attracting Italian doctor in order to improve their knowledge in robotic rehab. So please, Kristina, we are ready to listen to you, and a greeting to all participants.
Thank you, Professor Michele Vecchio. We really appreciate your contribution to the debate. Now it is time to start, so we cannot wait anymore. I present to all of you PhD Kristina Oidekrova. She will give us some useful and practical information about her studies, her job, and her clinical activities, specifically with post-stroke patients. Hi, Kristina. I am very pleased to leave you the word. Thank you.
Okay, so good afternoon from the Czech Republic. First of all, I would like to thank you for the invitation to this webinar and also for the kind introduction. As mentioned, my name is Kristina Hojdekrova, and in this webinar together, we should focus on robot-assisted therapy in neurorehabilitation. On the beginning, I would like to briefly introduce also our facilities, Rehabilitation Center Kladruby, in a short movie. Let me see.
Has provided medical rehabilitation, especially for patients with musculoskeletal injuries and operations, spinal cord injuries, and acquired brain injuries. We provide medical rehabilitation from
Christina, we cannot hear very well the volume. Maybe you can share again the video, selecting also share audio.
Up the lower left corner.
Lower left corner. Thank you.
Maybe I can skip it and I can explain to you how does it work in our center in the next slides. Okay. For now, we have here the first question. I wanted to a little bit introduce our facilities, but we move for the facilities a little bit later. And now I would like to know which is your profession and do you use robotic device for the rehabilitation field? So here we have possibilities answer. So I give you a few minutes to mark your profession or your study program. Okay, so we'll be for the results. I know that among you also some students of the different kind of study program. Okay, so we have the result here. I see most of you are physiotherapists. We have also a few occupational therapists, physiatrists, but also engineers and also the students. So thank you for your answer. And we can move to the rehabilitation of our facilities. Rehabilitation program offered in our center can be divided into two main parts. The first one is for the patient after spinal cord injury. For this patient, we have 40 beds, and it is for the patient who are in subacute disease. This hospitalization is dependent on the severity of disease and usually takes 3 to 5 months. Type of therapies is divided into some specific daily points. It is conventional individual and group therapy containing physiotherapy, occupational therapy, speech therapy, and psychologist intervention. These programs usually take 4 or 5 hours per day. Thanks to wide use of robotic assistive therapy for the upper and lower extremity, and especially for verticalization, can be provided a quality care. Moreover, we focus on optimal selection of equipment. For example, our therapists help select wheelchair according to an individual integrated protocol. And the rehabilitation also includes the regular sports activities for the patient using the wheelchair. It is, for example, boccia or archery. The second one we are going to talk about in this webinar, it is Cranio program. During this webinar, you will be acquainted with the more detailed information about the Cranio program. But for now, I would like to say briefly that our Cranio program is aimed for the patient after acquired brain injury and based on intensity and repetitive exercise provided by robotic device. Very important is transfer to clinical practice. Firstly, it is necessary to start with a short description how robot-assisted therapy fits into the usual conventional therapy. If we talk about the rehabilitation in patient after acquired brain injury, we try to influence all these models during the conventional therapy. It is biomechanical model, motor control models, cognitive models, and sensory integration. During rehabilitation, we try to increase the movement of the limbs, reduce pathological interaction, restore motor control, improve attention, memory, creating strategy, but also improve sensory and perception of body in a space. There are some studies that indicate that the intensive repetitive therapy is needful for stroke patients to influence neuroplastic change in a brain. Some older studies from 2010 recommended 150 to 300 upper limb repetition in a duration of 20 to 30 minutes. And for lower extremity, it is among 1,000 to 2,000 repetition during one therapy. It is probably difficult to imagine that the therapist would be able to perform 200 flexion and extension with the arm in 30 minutes. Currently, to use the robot-assisted therapy perfectly fits into the rehabilitation process, which provides us the number of repetition, at the same time influences the biomechanics of movement actively or passively, affects the sensomotor system, and can be also combined with the cognitive training. Rehabilitation does not end in this stage. Conversely, it comes to the most important point in a whole process, rehabilitation process, when the patient must transfer the restored functions into normal life. The crucial points of the is to combine conventional therapy with robot-assisted therapy, and according to the studies, we are able to determine that robotic-assisted therapy is non-superior, but it is only one of the ideal complements how to scale up the conventional therapy. In rehabilitation, we meet two kinds of approaches. The first approach, and so far more common, is hands-on, the right one. For hands-on approach, it is typical conventional therapy where the therapist is more active and the patient is a more passive receiver of information. These are classic therapeutic techniques. The therapy has more goals, fewer repetitions, and content of the therapy is complex but not specific. And we know that stroke patients need a specific approach. The second one approach is the hands-off technique, where the patient is more active and the therapist intervened in the therapy only when it is absolutely necessary and the patient is unable to resolve the situation on his own. Deviation from traditional rehabilitation is most evident in neurorehabilitation. For example, the rehabilitation which is focused on neurological, congenital, or acquired disorders, especially the central nervous system. A hands-off approach is based on task-oriented therapy, which is specifically aimed to achieving the necessary degree of independence and self-sufficiency for the individuals. Now we have time for the second question. Which approach do you think is used in a robotic assistive therapy? We mentioned two main approaches. The first one is hands-off. The second one is hands-off. And the next possibilities, it can be both or maybe no one. So I give you a few seconds to answer. What do you think that it's usually used during the robot assistive therapy? And also maybe if you understood what did I explain in the previous slides. So I wait for your answer. Okay, I see that most of you think that it is both. It's not wrong, but we prefer that during the robot assistive therapy, we use the hands-off approach, because during this therapy, the patient is more active than therapist, and we try to find and patient tries to find a solution for optimal movement on his own. So robotic assistive therapy, it's more hands-off approach. Intensity and periodicity are basic specifics of this kind of therapy. The therapist must be expounded to repeat rigorous stimuli in order to capture and store information and influence higher control center. According to evidence-based medicine, high-intensity therapy is one of the therapies that is most effective in activating brain neuroplasticity. High-intensity therapy is based on practicing repetitive movements several times a day in order to repeat as many times as possible. The best known method of high-intensity therapies is constraint-induced therapy. I'm sure that you know it. We call it CIMT. The next one is body weight support treadmill training, various forms of robot assistive rehabilitation, and also exercise in the imagination. The all mentioned methods belong to the group so-called task-oriented training. Therapy must be conducted sufficiently intensively and in high repetition to apply the principles of promoting neuroplasticity. To meet these two conditions, robot assistive therapy can be very easily used in rehabilitation. According to some authors, too high intensity rehabilitation in the first 7 days after the attack may be dangerous in the acute phase, which in turn leads to the increase in the extent of the lesion and slows down the restitution of the motor function. In the acute phase of stroke, too high in intensity would be counterproductive. And at this stage, only a medium intensity of training should be recommended. Conclusion of this slide is that these specifics, intensity, periodicity, and motivation, influence neuroplasticity changes in a brain. Neuroplasticity is often described as a mechanism involving either restitution or substitution of function. There are currently strong indicators that both phenomena, restitution as well as substitution, are largely responsible for the functional improvement observed after the stroke. The restitution model suggests that the lesioned area recovers as a result of tissue repair, while its function is assumed by other cortical and subcortical structures, either adjacent to or remote from the damaged area. On the other hand, the substitution model suggested that functional recovery after a stroke occurs largely by behavior compensation, by which patients learn to compensate for their acquired deficits. It means improving the difference between the patient impaired skills and requirements of their environment. Other mechanism you can see on the slide includes a solution of the diasthesis, for example, the unmasking of originally inhibited existing network, dendritic sprouting, synaptogenesis, or neurogenesis. Just for interest, after the stroke, two important locations arise in the brain. It is penumbra and diasthesis. Doctors certainly know these terms, but therapists often do not encounter them. So I try to explain it just briefly. Penumbra is also often called ischemic penumbra, where nerve cells retain vitality with functional impairment during depolarization of the central membrane. According to the location of the penumbra in the cortical area, we observe the clinical manifestation, for us, paresis or plagia. Diasthesis is the distant neurophysiological changes directly caused by a focal injury. We have a different kind of diasthesis, as you can see on the picture. It can be, for example, functional, connectional, and so on. We have also different kinds of neuroplastic changes. Neuroplastic changes take place on 3 levels. The first one is the synaptic level. A change at this level is, for example, learning. Transmission on synaptic neural circuits has been modulated for a long time based on repeated external as well as internal information. The second one is the local level. At this level, it is a change of efferent. It can be, for example, partial denervation. Synapses that lose their connection subsequently degenerate, while the remaining undamaged input multiply and form the new functional synapses. And the last level is a multimodal level. At this level arise new relationships between different areas of the brain. The stroke affects the center distal to the side of the injury, and changes at this level contribute to the repair of this remote center. We have also different types of plasticity. Reparative plasticity is focused on efficiency and number of synapses, rearrangement and formation of new dendritic branches and axons, reconstruction of focal neural networks, and changes in functional relationships. The second one is reactive plasticity, in which is involved spontaneous brain modification, such as reduction of necrotic or apoptic cells, angiogenesis, neurogenesis, neuromigration, and so on. And the last one, the most important for us, is adaptive plasticity, which is most applied during the stroke. It is reaction to an intermittent, long-term recurring stimulus. And here we can see how robot-assistive therapy perfects fits into the neuroplasticity model, because we know that robot assistive rehabilitation provides us a long-term repeated stimulus. The robot-supported environment can be adapted to better engage patient after the stroke, because provide external motivation, support feedback, and learning strategy. At the same time, the therapy is focused on a real world oriented therapy, patient-centered therapy, and complex tasks. Currently, robot assistive rehabilitation for upper limb focuses on a new training strategy that are more oriented to the functional training environment and often are associated with the virtual reality. Increase in engaging environment positive influences neuronal plasticity and help to transfer restored skills to the real life. The goal of the robot assistive therapy is to increase the functional use of limbs, increase the use of functional in real life, and reduce the error of movement and learn non-use. Robotic assistive rehabilitation is widely used in many departments of rehabilitation, as you can see on a slide. It can be in neurology, pediatrics, geriatrics, surgery, and presently robotic assistive rehabilitation is also used in a psychiatry. There is mainly use virtual reality for relaxation and motivation. Now is next question for you. Which are the exclusion criteria for robotic assistive rehabilitation? We have here the different kind of answer. Exclusion criteria. It can be cognitive deficit, wound, Parkinson's disease, spasticity, edema, scalds, bone fracture, and age over 75 years old. Maybe I explain just the difference between the wounds and scalds. Wounds, it is an injury to living tissue caused by cut, blow, or other impact. And the scalds, it's an injury with a very hot liquid or steam. So I give you a few seconds to think about your answer. Maybe it can be more than one answer. Okay, so we have a result here. Okay, I think that most of you have different opinion about the exclusion criteria. So maybe we can move to the next slides where we can check and compare your answer. So as you can see, most common contraindication is spasticity, which is higher according to Ashworth scale, higher than number 3. Then it can be epilepsy, severe visual deficit, or severe cognitive deficit. This is usually up to the therapist or also up to the severe of the deficits. So it's not has to be the strict contraindication. Then acute inflammation, damage of the skin cover. This is the wound, for example, fractures and other threatening condition. I noticed that some of you answered that Parkinson's disease is also contraindication. On the other side, I have to say that nowadays we have also some recently study which focus on the robotic assistive rehabilitation in patients after the Parkinson disease. So this is just the note that Parkinson disease, it is not contraindication to use the robot assistive therapy. You just have to be careful to use it in this patient. Okay. Now, the division of the robot assistive rehabilitation. First of all, is division according to location. I think that is very clear and easier. It can be a robotic assistive device for upper extremity or for a lower extremity. The second division is according to constructure of the device. The first one is exoskeleton. The advantage of exoskeleton is precise coping of the upper limb, tight alignment to anatomical axis and multi-joints, which is corresponding to the mechanical of the joints. In addition, joint ranges, angles, and torques can be measured, resulting in a relationship between joint angle and torques, for example, impedance or stiffness. The second one is the end effector. Using the end effector cannot be obtained angles in shoulder, elbow, and wrist torques, and independence with impedance without additional kinematic measurements or the connection of external sensor. For severe stroke patient, the end effector device can be also equipped with the orthesis on the forearm for a more comfortable attachment of the limb. The end effector robots often have a lower range of the motion because they are placed in front of the patients or slightly from the side. On the other hand, in patients with severe deficits, the advantage of the end effector is that the therapist can see the whole limb better and can tactile control the optimal muscle involvement. Some end effector system has been developed for bilateral training, where there are two distal points. One point is active and second one is passive. Now we have the question, are you able to recognize an exoskeleton and end effector? Here you can see the picture, and you can mark if geo end effector of exoskeleton or locomat, if it's locomat, exoskeleton, and end effector. I remind that the end effector is in connection with the patient in a distal point of extremity, and exoskeleton copes all upper or lower, in this case, extremity. So I give you a few seconds to think about your answer about the exoskeleton and end effector. I hope that it will be very easy for you to answer. Yes, and here we have the results. So many of you have a correctly answer. So geo, it is an effector construction, and the locomat, it's a construction of exoskeleton. Why? I explain again. You can see that in a geo, the patient is in a contact with the device only with the distal part of the lower extremity. On the other hand, the locomat, you can see that there is a construction, there is an exoskeleton which presses copies all lower extremities. Yes. Okay, so we can continue for the next slides. The next division is according to feedback. Feedback is very interesting tools of the rehabilitation. I'm sure that you've also used it in your therapy or during your therapy. Biofeedback can be defined as a tool through which hidden psychological processes are more apparent. Biofeedback affects the motivation of patients to engage in therapy, especially those patients with cognitive or sensomotor deficits. Biofeedback can further improve nerve reorganization through the existing brain and spinal pathway. Biofeedback therapy in patients with motor deficits should lead to re-education of motor control during dynamic movements that focus on functional goal, task-oriented therapy. Thus, it does not primarily focus it on the static control of one muscle group and joint. Early form of biofeedback were mainly in form of visual and auditory, as you can see on the right picture. And the new forms of biofeedback use multimedia or virtual reality. The 3D environment has two goals in rehabilitation. It enables therapists to set up repetitive and functional ADA training, and the large robotic devices in medical, and the second one is at the same time offer patient optimal feedback. Another wide use variant of the biofeedback is using EMG, as you can see also on the picture. This type of biofeedback is in the so-called hybrid assistive exoskeletons, which allow patients to train in a home environment and at the same time provide information and repetitive training similar to large robotic devices in medical facilities. So it's also very useful. Last but not least is haptic biofeedback. It's quite new type of biofeedback, which allows the patient to communicate in manipulation virtual objects. Haptic information supports kinesthetic sensation while helping the patient to immerse themselves more into the virtual environment. The last division is depending on the complexity and the focus of device. Device can be offered, unimanual or bimanual approach. We will also speak about it, or it can focus point-to-point training or functional training. What are the advantages or disadvantages of using robot assistive therapy? We can see that it is 50-50. Advantages: device provides repetitive training, high frequency, effectiveness of the therapeutic time, but also economically increase motivation of the patient to participate during the therapy, and also it is ergonomics for the patient, but also for the therapist. Disadvantages: the human elements is missing and elements of socialization. I am sure that everyone who has already had therapy with the patient knows that some patients more talk than train. So for these types of patient, it can be a problem to use the robotic device, or it can be uncomfortable, for example. For this patient, it's better to use the conventional therapy, or as a therapist, you can motivate this patient to use the robot assistive rehabilitation. The next disadvantages are cost. Of course, it's up to the facilities, also the space. For example, in previous slide, we can see the Geo or Locomat. Those devices are quite huge, so it's also necessary to have the space for this device, which can be also sometimes problem. And the last but not least is trained staff. Here I've listed the most frequented used therapeutic approach, therapeutic technique. Conventional therapy is often combined with the physical therapy, and we are increasingly encountering the application of botulotoxin to upper limb, which is associated with the new concept of guiding self-rehabilitation contracts. I don't know if you already heard about that or if you use in your practice, but it is also a very interesting topic anyway in rehabilitation. But back to the robot assistive therapy, the conclusion of the most critical trial is that robot assistive therapy is not superior to other therapies. A combination of conventional therapy and robot assistive therapy is always important. I would like to mention one study that compares electric stimulation, which is also very often in clinical practice. In this study, they compare electrostimulation group with the robot assistive rehabilitation group in repetitions. The conclusion of the study was that the robotic assistive therapy provided a higher number of repetition of movements. That was exactly 24,000 repetition, which were divided into 4 types of movements, compared with the control group with electrostimulation. And during electrostimulation, that was only 1,800 to 2,400 repetition, and it was only during one direction, and that was dorsal flexion in a wrist. At the same time, study points out that electrostimulation cannot be used in a higher number of repetition in order to avoid diverse requirements of the motor units and fatigue of the targeted muscle. This problem can be easily solved by changing the motion assistant if we use the robotic assistive rehabilitation. Originally, robots were created only to train isolated ranges without functional focus. Over time, rehabilitation in this area began to focus on functional robot that masters the various stages of gripping and manipulating objects. One of the first such devices was, for example, Adler, which enabled to practice of drinking and eating, grooming, but also leisure time activities as tic-tac-toe. In general, in neurorehabilitation, the current trend is to move away from pathology. It means what does not work, where is a problem, and conversely focus on function. What has potential? This is very important information, that we stop to focus on pathology, but we want to focus on function. We want to see the positive factors. The most often encounter we most often encounter three modes in which we can practice. As you can see, the first one is the form mode. It's most often used when the patient learns a new isolated movement, reduce pathological interactions, straightens a specific group of muscle. This is a predefined trajectory along which the movement is guided, as you can see on the picture. The second mode is a functional mode, which is not defined by a trajectory, but is defined only by 2 points, the beginning and the end. And it's up to the patient how to get to the end point. For patients with a mild deficit, we usually use the free mode, normal mode, with no forces, no assistant. And it is usually used to increase fitness and muscle strength. Based on evidence-based practice, in a severe to moderate patients, usually we start with the form mode, where we teach the optimal movement stereotype. Then functional mode, we continue with the functional mode, where we teach the functional use of learning optimal movement. And finally, we use the free mode to increase the condition of such learn functional movement. As you can see, during the robot assistive rehabilitation, we can also set up the different kind of assistant. It can be guided, it's like passive movement, and all movements does the device. Then initiated, it means that patient starts the movement and the robot device finished the movement. Then step initiated, it's 50-50, half to half, 50% the patient and 50 is robot assistive device. And then the follow the assist, it means that if the patient stop to do movements, cannot continue, the device finish the range of the motion. And the last one, as I mentioned, is the free. It means that it's completely active movement of the upper limb or lower limb. Now, the next question for you. Do you know what is the action observation therapy? So I give you a few seconds to answer because you have only 2 options. So I think it will be quickly answer. So do you use action observation, or do you know what is it actually? Okay, so it's really 50-50. So now I explain to you or give you more information. What is it? The action observation. Action observation is defined as a dynamic state during which an observer can understand what other people are doing by simulating the actions and the outcomes that are likely to follow from the observed motor act. Action observation exploits a well-known neurophysiological mechanism by which the brain matches and observes action to its motor counterpart. This phenomenon is supposed to occur via the activation of the mirror neural system involving the posterior area of cerebellum, the inferior parietal lobe, the premotor cortex, and the superior frontal gyrus. There is growing experimental evidence that motor area are activated not only when activity is actually performed, but also where performed is the imagination or observation. Action observation therapy is also used in connection with robot assistive rehabilitation, as you can see on the right picture, where the individuals first observe the decelerate movement, and then with the help of a robot tries to evoke the movement itself with variation or varying degree of participation assistant. It is mainly the activation of the presental motor cortex and also the posterior region of cerebellum. And maybe one interesting things, action observation therapy can be difficult for patient after the stroke or with the lesion in a Brock center, which is one of the cortical area activated by observation of hand or mouth movements. These patients with the frontal aphasia have specific disorders to correctly code to observed actions. As you can see also on the picture, in left picture we have the conventional mirror therapy. I'm sure that you know this kind of therapy is used for many years actually. And on the right picture you can see the modern form action observation therapy via Gloreha device. I think that it was enough about the theory, and now we move to something more interesting. We move to the practical thing, and on the beginning of this second part of the webinar, I prepare for you a short video. I hope that it will work.
Hello, Christina. Thank you
Yes.
for the video. We can see it very well, and maybe you can comment what the glove is doing, what the device is doing. For those who don't know yet this robotic device. Thank you.
Okay, so I hope that you heard me. And in this video, we can see the different kind of possibilities, how we can use the Gloreha, how we use it in our rehabilitation center. You could see the passive mobilization, active assisted mobilization, bimanual approach via Gloreha, and also the using of the active sensor. Usually how we set up the Gloreha in our rehabilitation center, the length of the therapy with Gloreha is usually about 20 to 25 minutes per day. And usually our patient has about 10 to 20 therapies during the hospitalization. Here you can see also the functional using of Gloreha, how we train the manipulation with the object. This kind of manipulation usually we use in patient after the stroke and after acquired brain injury. For the patient with spinal cord injury, usually we use only the passive mobilization because the deficit is usually more severe on the upper extremity, and for spinal cord injury, if it is difficult to do movement in a higher range of the motion. This kind of therapy is very good for the patient with a mild paresis. It means that patient with the mild paresis manage extension or flexion of the fingers, but for them it's difficult to do these movements in the full range of the motion. So this kind of therapy is very good because, as you can see, during the therapy is used sensory glow with the passive mobilization. This kind of therapy is very good for the patient who needs more muscle power, increase the muscle power. It's very good motivation for them. And the last one, it is a using of the interactive sensor. As you can see, we use it in different kind of position. In the right low corner, you can see that the sensor is on a lap. In this position, we usually use it for the spinal cord injury patient. And the next position usually we use for the patient after the stroke. Okay, so we can move to the next slides. In our center, for each robotic device of upper extremity, we have a protocol, how and when to apply the device. As a demonstration of protocol, I chose the device Gloreha because I personally work the most with Gloreha, and this device is also, or was also, the part of my PhD thesis. Now I would like to share with you the results and protocols of clinical studies with Gloreha. We cooperate with the foreign clinics, so our studies are also multicentric. Our protocol are based on 15,200 therapies in 2014 and 2021 in these years. and 6,129 therapies were administered in cranial program, acute and subacute stroke, and 9,082 therapies were administered to patients in chronic stroke, multiple sclerosis, spinal cord injury, and so on. Based on evidence-based practice, our evidence-based practice, we created 4 basic therapeutics protocol for patients after acquired brain injury in subacute and acute phase. The first protocol is aimed at patients with severe deficits, severe paralysis. For imagination, I've listed the basic findings that occur in such patients. We are talking about the Gloreha, so we will focus mainly on the upper limb. According to MAS, it means modified S4 scale. The muscle tone of the finger is less than or equal. Number 3, there is no active movements of the finger. Pain on a pain of scale of pain 1 to 10 can be painfully. Hypersensory, edema, increased sweating, and decreased proprioception. Based on the knowledge of neuropathology after the stroke patient, we know that the most difficult to restore movement and motor control are isolated finger movements. For this reason, in severe patients, we'll choose exercise that do not contain isolated movements, but conversely are multidigital movements. I remind you that we're talking about the patients with severe paralysis who have a complex deficit: attention, memory problems, aphasia. Before each exercise, action observation therapy should take place, not only for premotor learning, but also for executive processing, initiation of attention, and understanding of content of therapy. We know that spasticity responds to the rate of stretching. For this reason, the exercise should be set at a lower pace, leaving break, pauses, inflection, and extension to realize the change in position. It is also important to gradually increase the range of the motion when it is necessary to respect the technical capabilities of the device. There should include less exercise in lower duration to harmonize rhythm and relaxation. In our case, the goal is to decrease muscle tone and increase joint range or reduce swelling or pain. Perhaps it's also it is also very important, and I would like to emphasize circulation and prevention as very important the goal. The second protocol is focused on patients with moderate paralysis. Again, I've listed the basic characteristics that have the greatest relationships to our topic. But of course, we can reconcile other phenomena that these patients, such as coordination disorders, dexterity, and degrees of motor pace. If we compare this protocol with the previous protocol, we see that the deficit according to modifier S4 scale is already lower. Number 2, there is a sign of flexion, finger movement. Pain may subside. Sweating persists because we know that sweating does not correlate with the severe of paresis, and hypo or hypersensitivity may occur. We include more exercise in a shorter duration. We also include functional exercise and opposition of the thumb. Again, we gradually step up the ranges of the motion and only extension break remain. The goal remains similar as in a previous protocol. The difference is that we try to support the initiation of movement and expand the already minimal restored communication channel between the brain and the hand. Now I prepared a short video of immediate effects after the Gloreha. It is in patient with the mild paresis. As you can see, as you could see, after the Gloreha, the patient has the higher range of the motion, and also the motor pace was higher than before the Gloreha. The protocol for mild paresis changes quite significantly. Mild paresis has only a slightly increased muscle tone, limited active movement, minimal functional use, very weak muscle power, incomplete range of the motion, versus edema, and there can be pain in the end of the ranges. In mild paresis, the exercise begin with the warm-up, multi-digital exercises, then there are isolated finger movements, and finally a functional digital grip. The individual exercises are performed in a higher speed, in a shorter length, and in optimal physiological ranges. We can notice that as the severity of the paresis decreases, the number of possible goals of the therapy increases. Emphasis is placed on increasing active movements, functional, muscle-selected motor control, coordination, and also dexterity. Last protocol is is dedicated to patient with plegia. Patient with plegia have hypotonia, zero muscle strength, pain, swelling, proprioception disorder. Very often they have neglected limb, and they have the problem in area of body scheme. Exercise is based on opposite principles than in spastic patients. Conversely, a fast alternating exercise is necessary in high repetition, of course, again, in optimal physiological ranges, and what is important, without the break in a flexion and extension. Also, the individual exercises are shorter and alternating multi-digital, isolated and functional exercise. The goal in plegic patients are relatively clear, according to me. Increase muscle tone, increase attention to the limb if it's neglected. Also include the upper limb to the body scheme, reduce swelling and pain, and most important is maintaining the range. I would like to emphasize that maintaining the range of motion. In the first stage of the stroke, it may be a so-called pseudo-weak paresis, which has a clinical picture of plegia, but over the time, the tension increases. The second risk is that it is a percentage paraplegia, where it is not the primary elastic barrier, but the psychological barrier shifts to the pathological barrier. There is a risk of damage of the small joint of the hand, interphalangeal, especially interphalangeal, and the risk of hypermobility. Now we have a time for your questions. I see that we have a few questions here.
Thank you, Christina Odekrova. Yeah, we received many questions, and we collect the most interesting ones.
Okay.
So let's begin from Regina Maniam. I am sorry for my pronunciation. And the question is, hi, does the activity, for example, staking blocks, comes in the manual or software, or therapists can create functional activities accordingly? Thank you. I think the question is if therapists can create activities, or the software offers a specific therapy. I
don't know if it's mean only for Gloreha or in a general or robotic device. About the second part of the question, about the software, I think it's more on a technical workers. Usually therapists cannot change the software or programming, but sometimes you can, to the system, you can edit, or you can programming the part of the therapeutic programs. So of course that it's up to the therapist if you want to edit something functional training with robotic device. So it's up to the device which you want to use. I hope that I answered you.
Thank you, Christina. Yes. We have another question from Joanna. If you can compare Gloreha with Armeo.
Okay.
I think the different use, or
okay, actually you can see, or if you know these two devices, I'm sure that you know it if you ask for it. Armeo, it's exoskeleton, the construction exoskeleton, and Armeo is focused on a whole upper extremity. As I mentioned during the first part of presentation, Armeo offers you the different kind of assistant. For example, it can be passive training, it can be also the active training. We have different kind of Armeo, so I don't know which one you mean, but the biggest difference is that Armeo is focused on a whole upper extremity. On the other hand, the Gloreha is focused on if we talk about the passive mobilization, or the mode of Gloreha which use the glow, not the sensor but the glow. This kind of Gloreha is focused on rehabilitation only the terminal part of the upper extremity, but very deeply rehabilitation of the hand. You can train active and also the passive movements. And if I focus only on the hand, Gloreha has more detail and specific training of rehabilitation. Okay.
Thank you, Christina. We have another question from Eduardo from Uruguay.
Okay.
And he asks, the digit extension is active or passive when you use the glove? Can you regulate the amount of assistance? Thank you.
Thank you for the good question. Maybe it wasn't noticed from the video, very good. But if you use passive mobilization with Gloreha, the movements are passive. You have in a glove the special roots who do the movements. So it's passive via the roots. But you can also use active assistive mobilization, also via the sensory glow. And in this mode, it's like 50-50. Some things it's active movements and some movements are passive. The second part of your questions, yes, you can set up the range of the motion via the roots. So there are the special part of the roots where you can set up the range of the motion. Also, for example, if you have patient who have painful, for example, or edema, that the range of the motion cannot be full, you can also set up in a program of Gloreha that for therapy, you only for one therapy, for example, you want to decrease the range of the motion. So two possibilities. You have to set up the range of the motion with the roots or in a system of Gloreha.
Thank you, Christina. I will read another question from Emre Beykan or Beysan. I'm sorry if I do not say well. Anyway, he's a PhD in Singapore on the robotic rehabilitation for stroke patients. So specialized as you in this field. And he asks, I want to ask you, what do you think about the virtual reality technique for the stroke treatment, especially combining this technology with robot-assisted therapies is looking so effective. What is your opinion for it? I believe the high-cost therapies can be moved from hospitals to homes and can create home-based therapies, especially for the chronic stage of stroke. This is a long question.
Yeah, it is quite so. So the first part,
yeah.
I keep it in my mind. So,
yeah.
The first part about the virtual reality in a stroke and my opinion. I think that it is very interesting to use the virtual reality, but according to my practice, we also some virtual reality glass, for example, or some sensor who provide virtual reality. It is interesting, but in a practice, it's a little bit difficult to apply. We work with the patient who have severe deficit, complex deficit. And we try with them, for example, the VR glasses. And I think that it was not so comfortable as it looks like. And I think that the studies are still in an experimental phase, and we need more evidence for stroke patient, how to use virtual reality, which conclusion, what inclusion exclusion criteria has. For example, I think it's not good for the patient with epilepsy. So it's still in a process, in a research process, and I think maybe it is a future, it is our future, but nowadays I think that we are in a robotic assistive rehabilitation, and we use only the piece of virtual reality. For example, that we use, for example, Kinect. You know it, I'm sure, Kinect in combination with robotic rehabilitation. but not only the virtual reality. And the second part of the question, I forgot it, so sorry.
Do you need I read it again?
The second part, please.
Yeah. I believe the high-cost therapies can be moved from hospitals to homes and can create home-based therapies, especially for the chronic stage of stroke.
Okay. Thank you. It's a really important point, actually. Home environment rehabilitation. On the end of this webinar, I'll also will talk about it. How does it work in a home environment? I think it's very hot topic. It's telerehabilitation and distance therapy, which use the I don't want to say robotic device, but smart technologies, let's say. And yes, I think it's a future. It's a future because we have many patients after the stroke in a chronic phase. And we see that also in this phase, the patient can improve. So it is important to fix the rehabilitation for this patient in home environments. And I think it is possible thanks to use the smart technology. But I think that it has to be low-cost technology, not high-cost technology. Okay.
Thank you, Christina. I will read one last question, but just because we don't have enough time. So the last one is from Jigan Silvaraja. What are the current challenges in integrating robotic rehab in current facilities without a robotic system? Thank you.
Maybe can you read it again, please?
What are the current challenges in integrating robotic rehab in current facilities without a robotic system?
Okay, so first of all, in one slide, I mentioned the benefits and the disadvantages of the robotic device. I think that if you think or you consider to buy some robotic device in your facilities, very important is to consider for which kind of patient you would like to use it. If you want to use it for the orthopedic patient or for the neurological patient, and according to diagnosis, according to your patient, you have to consider which kind of device. So it's the first of all. And the second point is we know it's not like top secret that these devices are not cheap. So for some facilities, it can be also the question, for some facilities, it's question the cost. So it's very good if it's the device uses for different kind of diagnosis. If you can use for as many as possible patients which you have in your facilities, according these rules, you can choose your device to the facilities. Also, I mentioned the space. So of course, if you have some small clinics or something like that, of course that you cannot buy some huge device. So you should prefer something smaller, but also you have to fix it according to your device which you have, the benefits and the disadvantages.
Thank you, Christina. Very clear, everything. Now, we would have other questions, but I am afraid we don't have enough time for everybody. So we will try to reply to all those people who ask a question later at the end of the second part of your presentation. And if we cannot, we will try to give an answer in another way. Okay, so now I pass the word again, and we can continue your presentation. Thank you.
Okay, thank you for your question. And now back to our webinar. In this part of the webinar, I would like to briefly show our results. This study includes preliminary data on 33 patients from the Czech and Italian facilities, so it's one of the multicentric study. Patient had 20 therapies with the Gloreha robotic glow. Patient were evaluated before and after the therapy, after the end of the 20 therapies. There were statistically significant results at the level of significance P.008 according to motor assessment scale of category 8, advanced activities. And according to the subscore motricity index, there was a statistically significant improvement in muscle strength in the fingers on a P-level point 0.19. The conclusion was that the robotic rehabilitation with Gloreha has been easily introduced in the clinical settings of different national health systems, and it can be useful to promote the implementation of a common standardized rehabilitation protocol for the post-stroke patients, even in a case of different culture background. During subacute rehabilitation phase of post-stroke patient, robotic rehabilitation Gloreha can be rapidly and effectively integrated to task-oriented exercise, occupational therapy, physiotherapy into multidimensional protocol. Gloreha can help to maintain undercaudal spasticity and promote hand and finger motor recovery. These are results of our second study. When during the hospitalization in our center, 20 patients underwent 20 therapies with Gloreha, and they were interested in the lasting effect of the therapy. All patients completed the same intensity of rehabilitation in the cranial program, and we evaluate 6 months after the discharge of this program. No one of the patients had individual occupational therapy within 6 months of admissions. Only non-specific physiotherapy focused on lower extremity and electrostimulation. Currently, we are working on statistical evaluation of 20 patients, but we know that according to books and block test was improved 50% of patients, and according to motor assessment scale in category 7, 55 patients, and in category 8, it was 45 percent of patients. So we hope for statistically or at least marginally significant results. Now, this is my study. This is study of my PhD thesis. The aim of the study was, the main aim was to evaluate and compare effectiveness of two therapeutic approach. The approach you can see on the picture, one of was unimanual and the second one of bimanual. It was a quantitative research and monocentric randomized control study. I assessed the patient at T1 during the initial testing, then after the 15 therapies, and then after 1 month after the finished Gloreha therapy. As assessment, I use the motor activity log for upper limb, motor assessment scale, action research arm test, box and block test, and motricity index for upper extremity. Here you can see the results. To the study were included 40 patients. who were randomly divided in two groups. First group, group 8, had the binaural approach with the robotic assistive therapy with the action observation 1 minute before the session and then action observation during the therapy. And the second one, group B, had a unimanual approach with the Gloreha and action observation was only during the passive mobilization. According to the assessment, we can see that we have a few statistically significant results. After the finished 15 therapies with Gloreha, we had the statistically significant results in motor assessment scale and motricity index for the shoulder. And the marginal statistically significant results in motor activity log and motricity index in total score. After the 1 month, after the finish Gloreha rehabilitation, we have the statistically significant results in motor assessment scale in both category 7, which is hand movements, and 8, which is advanced activities for the hand. And then we had the statistically significant results for the motricity index for elbow. Marginal statistical significance were in motor activity log and motricity index for total score. For many times I mentioned our cranial program of rehabilitation center called Ruby. So now I would like to explain a little bit detail what does it mean. Only patients who meet these inclusion criteria can be admitted to the cranial program. Entry criteria include age, diagnosis, and indication of at least 2 specialties. It is important that the patient is cooperative. That means it's lucid, may have percutaneous endoscopic gastrostomy, but not an artificial lunch ventilation. And furthermore, the patient has to have a cooperating family and be internally stabilized. Now we have some number which can be interesting for you. In the year 2015 to 2021, 731 patients were admitted to the cranial program, and their average hospitalization was 66 days, although the maximum possibilities length of the hospitalization is 90 days. A very important indicators is where patients are discharged from our cranial program. As you can see on the left picture, 621 patients were discharged to the home or family environment. 52 patients were transferred to hospital for planned operations, such as some craniosurgery or due to complications such as epilepsy. 6 patients continue to another rehabilitation facilities, and 30 patients were transferred to nursing or elderly home. The second very important indication is the nursing categories, which tell us the degree of self-sufficiency and help that patients need. There are a total of 4 categories. I just explained what does it mean. The category 1, there are patients who are self-sufficient and they do not need above standard nursing care. In category 4 are patients who are immobile, have a severe complex deficit and need constant care. What shows us the second graph, the nursing category? We see that the most patients were admitted to category 3 and 4. It means patients with severe deficits. After 66 days of rehabilitation, patients improved and more patients were in a category 1. It means fully independent, and only 54 patients remain fully non-self-sufficient at the discharge time. Now, is the last questions for you. which is the ideal time for rehabilitation treatment for a stroke patient. Here we have a possible option for the answer. It is 1 hour per day, 2 hours per day, 3 hours per day, 4 hours per day. The more, the better. The more, the better. Okay, so I give you a few seconds to think about the length of the rehabilitation after the stroke patient. I would like to mention that we think this patient in a subacute phase. This is can be a little bit difficult for you. Okay, so here I see that few answer is for 1 hour, 2 hour, 3 hour, and 24% is for the more the better. Okay, I have to say that this was a little bit trick question. Because basically no answer is totally correct. The intensity of therapy must be always set according to the patient condition and the severity of the deficit. Based on our evidence-based practice of cranial program, patients with the severe complex deficits show that optimal duration of individual therapy is around 3 to 4 hours per day. So that was a little bit tricky question. And now, only briefly, I would like to show the intervention in our cranial program. As you can see, in our cranial program, patient has 1 hour of physiotherapy per day. It is individual therapy. Then they have also the group therapy. It is group in a gym and group in a pool. The most common deficits are verticalization, prevention of bent shoulder, pathological movement of lower and upper limb. And in intervention, usually we use the conventional therapy, robot assistive therapy for lower limb and verticalization. We focus on education and recommendation of the aids, for example, wheelchair, Vero, and so on. And we also focus on positioning of the limbs. As you can see on a schema of 735 patients who were included or admitted the cranial program, 624 patients needed the individual therapy in high intensity. Then the next intervention is occupational therapy. Is the same as in physiotherapy. The patient has have 1 hour of occupational therapy per day, which can be divided into 30 minutes therapy. Then they have group therapy, which is focused on gripping. Then graphomotor skill group and OT handcrafts. The most common deficit in occupational therapy is self-sufficiency, immobility, malfunction of the upper limb and apraxia, muscle tone imbalance, spasticity management, and neglect syndrome. The intervention is quite similar as in physiotherapy. We use the conventional technique, we use the oscillation therapy, robot assistive therapy for upper extremity and for the training of cognitive function, and also we educate and consult with the patient and family, especially the aid to bathroom and the kitchen. As you can see on a schema graphs of 735 patients, 644 needed individual occupational therapy in higher intensity. The third intervention is speech therapy. which is also 5 days per week. Also, one therapy is for the length of one therapy is 60 minutes. And then we have two groups. One is dysphagic and fatigue group. The most common deficits are aphasia, dysphagia, agraphia, speech apraxia, and alexia. And the intervention, again, conventional speech therapy techniques. They use also oscillation therapy. They use the visual biofeedback for swallowing, electrostimulation, and they do educational and cold something. As you can see in the scheme, 443 patients of our 735 patients needed individual speech therapy in higher intensity. The last intervention is psychology. We have the psychology 5 days per week. Every day, patient has 30 minutes of PC cognitive training, and the individual training is according to patient needs. The most common deficits are memory, executive function, attention, strategy creation, and neglect syndrome. As you can see, 625 patients needed high intensity of individual and group psychology intervention. Just for interesting, I just prepare for you a sample of patient daily rehabilitation program in cranial program. You can see that in the morning the patient starts with occupational therapy, which takes place in patient room. Then patient continue with cognitive training, prismatic adaptation. It is neglect syndrome treatment. Then it's individual physiotherapy, dynamic splitting, group therapist, and in the afternoon continues with the individual and group therapies, which included also the robotic assistive therapies. Maybe some of you are interested in why the left column is red. It's because this schedule is made for the patient with left neglect syndrome. This webinar was mainly devoted to robot assistive therapy of upper limb. So at the end, I would like to briefly show the part of robotic center for lower limb. So here you can see the Erigo. Usually we use it for a stroke patient who have a severe deficit, usually on a beginning of hospitalization, where we need to verticalize then and then to train the joint. Or we use it for spinal cord injury as prevention and so on. Here you can see the Locomat, which is according to me still gold standard in locomotion rehabilitation. We use it also for the stroke patient, multiplex sclerosis patient, spinal cord injury patient, and many other diagnoses. Here you can see the real ambulator. This device I really like using for the training of quadruped coordination, especially for the patient who has the problem to start to work without some wheel and some crutches or something like that. We train quadruped coordination. It means that the patient working on the treadmill and doing the walking also do use upper extremities. You will see in a few seconds. Here you can see the training of quadruped coordination of 4 limbs. Okay, and the last slide is devoted to the current hot topic, as I mentioned in a short discussion. It is telerehabilitation. 2 years ago, we started a distance therapy program that follow on our cranio program. Patients who needed subsequent rehabilitation of at least 2 interventions were again included. 1 year ago, we extended distance therapy to rehabilitation, which includes not only patients after the stroke or TBI, but also patients with vertebral algic syndrome, Parkinson's disease, cerebral palsy, patients with respiratory problems, and patients after the COVID infection. Therapies are either individual or group. And all therapies take place via our secure e-ambulance platform, which is simple, user-friendly, GDPR compliant, and provides a data record of evidence the therapy, for example, for health insurance companies. And in lower part, you can see our website, the links of our website. So if someone interested in the telerehabilitation of distance therapy, you can contact us via these links. In conclusion, I would like to say that the repetitive, intensive, and high-frequency therapy can be administered using robotic-assisted system. And the conclusion of the most study or clinical trials is that the robot assistive is non-superior to other therapies. Conversely, a combination of conventional therapy and robot assistive therapy is very, very important. Okay, and I thank you for your attention.
Cristina De Crova, thank you. We have just a few minutes more, and we exploit for last questions. Maybe we will not have enough time for everybody, but let's start with Neha that asks, hi, last webinar regarding Gloreha, the speakers said it's most beneficial for spasticity with the slow repetitive and movements. Spasticity can be reduced in patients. Mm-hmm. So with repetitive and movements, sorry, but I don't know how it's written, can be reduced in patients. Today, you mentioned its contraindication with mass more than 3, so Ashworth mass scale. So it's useful or it's contraindication. So I think the question is if it's a contraindication to use Gloreha with mass more than 3 in the Ashworth scale, modified Ashworth scale?
Yeah, thank you for the questions. It's very important. Yes, I mentioned that there is according to modified S4 scale, if it's higher than number 3, it can be contraindication. Higher than 3, it means 4, and 4 is according to S4 scale that there are some construction, or you cannot extend very, very easily during the very, very slow stretching of the muscle. The contraindication in Gloreha, it is because there are also the limitation of the roots of the glow. So and it is my practice because we try it also to apply Gloreha for the patient with higher or very high spasticity. And if you apply Gloreha on a patient with very high spasticity, then the construction of Gloreha is a little bit, I don't want to say destroy, but the effect of the therapy it's not very good. So that's the reason why it's a contraindication. But I would like to say that it's up to the patient. Every patient is individual. So for some patient who has very high spasticity, it can be possible to apply Gloreha, even they have 3 according to Ashworth scale, but you have to set up a very slow slow base, and you have to choose very very good exercise, usually multi-digital exercise. So that's my answer.
Thank you, Christina. We have a second question from Chiara from Florence, from Italy. She's a young resident in physiatry, and she asks, have you studied the effects on neuroplasticity occurring during the period of treatment with Gloreha, especially with regard to the proprioceptive training? Thank you. Proprioceptive training. I'm sorry. Thank you.
Actually, we are not hospital, we are rehabilitation center, so we don't have here, for example, MRI or something like this, so we cannot focus exactly for the neuroplasticity changes. We assess only the clinical changes, what we see or what we can observe on an objective clinical assessment. And we focus especially for now, especially for the spasticity and the functional movement of the upper limb. But I think that we would like to focus also for the perceptivity.
Thank you, Christina. We will read one last question, and it's from Bojan or Boyan. How effective is RAR, R-A-R, after 2 or 3 years post-stroke? So rehabilitation, okay?
Okay, so your question, it's not for the subacute or acute patient, but it's also important to mention that Gloreha is possible to apply in a patient for the patient in chronic stroke, chronic phase. We use it in our center for chronic patient as well. We don't have a study yet for this patient, but according to my practice, the best benefit or the biggest benefit for the chronic stroke patient is the reduced edema, the reduced pain, and degrees of spasticity, and increase the relaxation of the muscle.
Thank you to PhD Christina Gloreha for all these answers. Your presentation was very, very interesting, and we really thank you for your great contribution to this debate. So I just want to inform all of you that we will schedule other dates for other webinars, as we just made with PhD Cristina Gloreha, and maybe you can see our next one. Okay, so it will be this month on the 18th of May, and it will be about the rehabilitation, neuropsychologist rehabilitations of attention function. So the doctor that we'll talk will be Alessandra Maietti from an hospital near to our company in Poliambulanza Brescia. I hope that you can join us as for this webinar, and I thank you for your attention and participation. And I thank above all Cristina for her great presentation. Thank you, Cristina. In the world, there should be more therapists as you that take care about us and our dear ones. Okay, great job.
Thank you for invitation, and have a nice day, all of you. Bye.
Thank you. Thank you. Bye.